X-ray.
Yeah, so this is a PA chest radiograph for an adult patient. There is an abnormality in the left middle zone where there is an area of increased density which appears to be silhouetting the left hilum as well as the left heart border. The margins of the density are quite irregular.
Yeah, good. So diagnosis?
So my primary diagnosis would be of a mass lesion, possibly arising from the hilum. It could be enlarged lymph nodes or a neoplastic lesion.
Yeah, good. So there is a, as you can see, there is a, can you see my mouse?
Yes.
As I'm moving, yeah. So there is a mass. And what's happened is that, did you notice that the left lung is smaller?
Not initially, but I can see that now, yeah.
And what about the blood vessels in both lungs?
They appear more prominent.
Yeah. On the
right.
Yeah. So is it the other way around? They appear sparse on the left side.
Yes.
Yeah. Yeah. So what is happening here? There is one thing that I would like you to mention. Something has collapsed. Do you think something has collapsed?
Yes, I think the left lung has sort of a diffuse hazy opacification relative to the right. So there might be a left upper lobe collapse.
Exactly, yeah. This is a classical 2B radiograph. So the learning points from this radiographs are to identify the transradiancy between lungs, to identify the difference in lung sizes between two sides. And then once you identify that, once you identify the difference in lung sizes, then you go to, that's a lateral radiograph of the same thing. We can see the upper lobe collapse and shifted major fissure. So once you identify that there is upper lobe collapse, so that's the CT. Do you want to comment on the CT and then I'll proceed to the differentials?
Yeah, so these are selected axial images of the chest, presumably the same patient. We can see that there is dense collapse of the left upper lobe with possibly some mediastinal shift towards the left also, and maybe a trace pleural effusion. So these findings would again be in keeping with the left upper lobe collapse. It appears to be due to a mass in the left hilum. Yeah,
yeah. So this is Chapman, unequal lung size and lucency. So what do you do when you find that the lungs are not equal in size? So number one, the learning point is that you should train your eyes to identify the difference in size between lungs and to identify the difference in lung lucency. Yeah. So once you do that, how do you proceed? This is really useful. If you know this, then you can diagnose quite a lot of things. For example, a foreign body aspiration in a child. The first step is to identify the lung sizes and lucency. So once you identify that one lung is small, left lung is small, so what's happening? Then you look at the blood vessels. Then it's basic Chapman then. If vascularity is decreased, that lung is abnormal. So which lung is abnormal in this radiograph?
Left.
Left is abnormal because blood vessels are sparse in comparison to the right. So train your eyes to identify the difference in vascularity between lungs. Now, if vascularity is normal or increased, that lung is always normal. Yeah. And the other differential that Chapman gives is that a small, completely opaque hemithorax is always abnormal. And the differentials are total collapse, pulmonary agenesis, and I will add pneumonectomy to it. People are activating their video. I would say please deactivate your video. And a lung not changing with inspiration and expiration are abnormal. Right? Okay, so that's the first radiograph. So unilateral hypertransradiant hemithorax. Differentials are rotation, poor technique, scoliosis, and then chestal abnormalities like mastectomy, polio, or Poland syndrome, and then pleural abnormalities, which is pneumothorax, and compensatory overexpansion of lung, airway obstruction, emphysematous bulla, macleoids, or congenital lobar emphysema, or a vascular abnormality, which is embolism. So we'll go to the next case. Can you describe the abnormality?
It's again a PHS radiograph for an adult patient. Straight off, there seems to be some asymmetry in the lung volumes with elevation of the right hemidiaphragm and slight crowding of the ribs on the right. Within the lungs itself, there appears to be an opacity in the peripheral left sort of mid-lower zone, as well as further patchy opacities throughout the right lung. Sorry, the screen's just gone fuzzy.
Oh, can you not hear the see the screen?
It's just a bit fuzzy, so the details aren't coming out as well.
Okay, I'm not sure what's happening there. Let me just check that again. Okay, I can see the X-ray quite well because I'm logging in and logging out. Yeah, and Samir Khan has just texted me. Screen is fine for him as well.
Okay, I think it's probably more my internet than yours then.
Yeah.
Okay,
right. So are you telling me you can't see the radiograph at all?
No, I can. It's just not very clear. But based on what I can see, yeah, as I was saying, I can see an area of increased density in the left mid to lower zone, which is
ignore that.
Okay. On the right side, there looks like there's maybe some patchy opacities in the right, upper and middle zones, and I can't clearly see the right heart border. The chest X-ray seems to be quite well centered, so I don't think it's projectional.
And what about the Hilar and mediastinum?
So the right hilum looks probably a bit higher than I would expect. It's more equal and in level with the left, and there's some.
Can you see the Hilar point? What is Hilar point?
Where it all sort of converges in and forms a sort of like an angular line.
Yeah.
But I can't see it clearly on here.
Yeah. So the upper lobe vein and lower lobe artery forms an angle that's called Hilar point. So you correctly told me that you can't see the Hilar point. So what's happening here? If you can't see Hilar point, then what does that mean? That means something is sitting in the hilum and masking it.
Yes.
So what can sit in the hilum?
So it could be lymph nodes.
Exactly. That's the most common thing. So you see an opacity in the right upper lung, and then dense hilum, and then there is mediastinal whitening, don't you think?
Yep.
Yeah. And then the left hilum is also a bit dense. So you see an opacity, mediastinal lymphadenopathy, possibly bilateral hilar lymphadenopathy. Differentials, I would say the patient is a smoker and recently developed hemoptysis.
So I guess your first differential with that history would be a lung malignancy, probably a primary with lymph node disease.
Exactly, yeah. That's good. So, while sitting the exam, you to the examiner, instead of asking for differentials, give examiner all the differentials. You see that you see an opacity in the right upper lobe, and there is mediastinal widening, there is hilar appear dense. So if this patient had hemoptysis and a smoker, I would consider primary lung cancer in the right upper lung and bilateral hilar and mediastinal lymphadenopathy. That would make the staging N2, because presumably there is bilateral hilar lymphadenopathy, but the final staging would be after CT. If you give it that way to the examiner, then the examiner understands that you're thinking beyond the X-ray, taking it to the next level. Okay, case 3 for you, candidate number 1.
So a PA chest radiograph for an adult patient, slightly rotated. There's an abnormality in the region of the right hilum where there's an increased density by a rounded, somewhat lobulated soft tissue mass. There's no widening of the mediastinum.
Yeah, fantastic. That's brilliant. That's all. Rest of the X-ray is fine. Mm-hmm. So you correctly picked up the opacity projected over the lower part of right hilum. This is the one you're referring to, isn't it?
Yes.
My mouse? Fantastic. So have you heard of hilum overlay sign?
Yes.
Yeah. So what do you want to say that's positive here, or would you say, do you want to comment on hilum overlay sign in this case and the differentials based on that?
So I would think that in this patient that it does look like the hilum overlay sign where it's sort of
good. So
it's against hilum, but you can still sort of make out the vessels.
Yeah, you can see the vessels. So so that makes this what then? What's the differential in this scenario with hilum overlay sign positive? So
does that bring into account, is it anterior mediastinal masses?
Right. Okay. That's very good. You're thinking out. That's what I want. These are the ideas that I'm going to share to you for the rest of your life, to be honest. So a mass in the hilum, sitting in the hilum, will obscure the hilar point, and you will not be able to see the vast structures through the opacity. Okay. Whereas in this instance, you can see the blood vessels through the opacity. Yeah. And the hilar point here is not obscured.
Yeah.
So that means this abnormality is not sitting in the hilum. It's either anterior to the hilum or posterior to the hilum. So what's anterior to the hilum?
So your anterior mediastinal mass differential.
To be honest, anterior to the hilum is actually the lung. Hilum is the point where the bronchovascular structures enters the lung, isn't it? That's the point where the bronchovascular structures enters the lung, and then lung encases, lung kind of spreads out in front and back of the hilum. I'll show you the CT that will make it easier for you to understand the concept. Anyway, the hilum overlay sign means if you can see the hilar structures, which are blood vessels, through the opacity, then the opacity is not in the hilum, but it's anterior or posterior in the lung. When I show you the CT, you will understand. So can you identify the abnormality in this X-ray? It's a bit subtle. So there is opacity there.
It's anterior to the hilum.
It's anterior to the hilum. So hilum is there. It's anterior to the hilum. And the fact that there is a lucency surrounding the mass means that it is not in the mediastinum. If it's in the mediastinum, it will be surrounded by soft tissue structures, and you won't be able to delineate its margins. It may be seen as a bulge of the mediastinum or a widening of the mediastinum. That's why we use the term widening of the mediastinum. It just seems widened. You don't see the medial margin of the opacity, do you? Okay, so that's the CT. Do you want to describe the CT?
Yeah. So these are selected mediastinal and lung window axial acquisitions of the chest. On these images, we can see a soft tissue density mass abutting the mediastinum, the right mediastinal border.
Yep.
It's got a reasonably irregular margin and appears to be extending into the mediastinal fat.
Yep.
It forms, in some images, an acute angle with the pleural lining, suggestive of it being within the lung itself rather than.
Diagnosis would be?
A primary lung malignancy would be my first differential.
Exactly. Now, you were a bit confused to whether to call it a mediastinal lesion because of the hilum overlay sign or a lung lesion. Yeah. Mm-hmm. So I will explain why it's a lung lesion, because that's the hilum. The hilum is the point where the bronchovascular structures enters the lung. Yeah. So on the right side, especially what's anterior and what's posterior, it's lung tissue. You see, so that's lung tissue. On the left side, there is more cardiovascular structures, but even on left side, if you look here, there is lung. So something that sits anterior or posterior to the hilum in hilum overlay sign refers to a lung lesion that's close to the mediastinum, as you can see. Now, you had a little bit of confusion whether to call this mediastinal or lung lesion, and you did say that it's got an acute angle and so on. But, you know, as you see more and more cases, you will understand a mediastinal lesion will be in the mediastinum. That's the mediastinal fat. Yeah. And it's unusual. It doesn't happen that way, that a mediastinal cancer kind of originates from the margin of the mediastinum, then grows into the lung. That's not a pattern that happens. So when you see a mass like this, no need to think twice. I'll show you mediastinal cases, and that will clear your mind about when to call something mediastinal and when to call something of lung origin. So that lesion, it's got a epicenter sitting inside the lung. It's because this was where it started, and then it grew three-dimensionally, and then when it reached the mediastinal margin, it did infiltrate the mediastinal fat. But if you look at the center of origin, it's in lung. Do you agree with me?
Yes.
Yeah. So we have another session on today itself on mediastinal masses. So I'll show you how mediastinal masses start. They start in the mediastinum and grow three-dimensionally in the mediastinal fat. They may invade the lung at some point, but primarily they originate in the mediastinum. Now, coming to the staging, Alexia, my colleague, is going to, in another session on chest, going to give you all the current staging for lung cancer. So I'm not going to elaborate on that. Okay, next case. Do you want to describe the X-ray? Yeah.
It's a PA chest radiograph, again for an adult patient. Both lungs appear to be sort of inflated with increased transradiancy, but I think that might be the projection because it's quite symmetrical. I can't see an obvious abnormality, so just tracing sort of through my normal system, the trachea central, the mediastinum looks normal, the heart size is normal, there's no obvious bulkiness of the hilum. Comparing the left and right lungs, there's some increased density in the left apex compared to the right hand side. I can't see any other similar increased density throughout the remaining lungs. No obvious bony abnormality. Okay, so on the CT sequences, I can see that there is a mass in the the left apex, which is sort of irregular and spiculated in margin.
Yeah, good. So that was a classical Hancock's tumor.
Yep.
Superior sulcus tumor. So review areas which you picked up very well. That's good. Next case.
Okay, so this is a lateral chest radiograph for an adult patient. I have to admit I don't look at these very often, but
that's why it's on the slides.
I think there's maybe some increased density sort of posterior to the hilar structures in the sort of
Is that the upper chest, mid chest, lower chest?
Say it's probably more in the upper chest, posteriorly in the upper chest. Reasonably well-defined margin. There's no obvious lobar collapse.
Yeah. Have you heard of spine sign?
No.
Okay. So we don't see as many lateral radiographs these days. For some reason, that's not a practice. Previously, it used to be frontal and lateral paired together sometimes. And now that practice is currently almost not there. Very rarely we do lateral radiographs, but an examiner might show you this, and that's the reason why this radiograph is there in the teaching files. So spine sign means that as you go down, the spine should become gradually more loosened from top to bottom. Yeah. So this means that if in the thoracic spine and lateral chest radiograph, when you see, it gets more and more loosened. So that's because the lung has larger volume in the lower lobes, and because lung is air, the density of the spine gets more and more loosened as you go down in a lateral chest X-ray. And I would have expected the lower thoracic vertebrae to be more loosened than the upper thoracic vertebrae. Right. Can you see a variation in density in the vertebrae now, since I have mentioned it?
Yes.
Yeah. So what's happening now, since I've given a clue, do you want to comment on that?
Yep. So projected over the lower thoracic vertebral bodies, there's an increased density relative to those above it.
Fantastic, yeah.
As you said, you'd expect it to be more lucent than that. I think you can probably also see that there's some increased density. So
one more question for you. So there is something abnormal going on there. Is it in the spine or is it in the lung?
I think it's in the lung. It looks like it's extending beyond the vertebral bodies.
Fantastic. Good. So we have learned spine sign, which means that as you go down in a lateral chest X-ray, the density of spine, vertebral bodies, that is to be precise, should become gradually less and less. They should appear more and more loosened. But if they don't appear loosened, then look for a lesion. That may be a sclerotic lesion in the bone. But as you correctly picked up in this instance, it is going beyond a bone. So there's only lung, actually. If you look at on both sides of the spine, on a lateral X-ray, there's only lung. So it has to be in the lung. This is same patient's frontal X-ray, PA.
So on this PA chest radiograph for the same patient, there is an abnormality in the left lower zone in the retrocardiac region. There's a rounded soft tissue density.
Excellent. So you did pick up the left retrocardiac opacity there. Yeah. Now, in your practice, even in exam, if you are given a lateral X-ray first, it's completely fine. I would have accepted it if you had asked for the frontal radiograph first. Okay. It's fine if you can say in your practice, you would be looking at, in practice everywhere in the world, you will be looking at a frontal X-ray, chest X-ray first, and then look at the chest X-ray, a lateral X-ray later, or at the same time. So, but you should start from a frontal X-ray. So it would have been completely okay for you to say, this is a lateral X-ray, but in normal practice, a frontal X-ray will be looked at first. So can I have the frontal X-ray, please? Yeah, you can say that. Good. We have done 30 minutes for number 1. So can you mute yourself, and can I request candidate number 2 to raise the hand, please? Good. Now, are you able to unmute? Because for some reason, candidate number 2. Hello? Yeah. Oh, yeah. Is that candidate number 2?
Yes.
Oh, fantastic. So, I was supposed to unmute you, but I think I have a help from one of our registrars, and she has unmuted you, which is brilliant. So that's your first X-ray.
So this is a frontal chest radiograph of a skeletally mature patient showing triangular opacity projected over the right lower zone. It does not silhouette the right heart border, although the mediastinum is shifted towards the right side. Also, it does not silhouette the diaphragm. So it's not a middle lobe nor a lower lobe opacity. I cannot see any other abnormality. The right hilum is unclear. I cannot pinpoint the right hilar point. Maybe it's shifted down behind the right side of the heart.
Good. So can you, you have picked up the findings. Can you arrive at a diagnosis? Give some idea what might be going on. You did describe all the abnormality, mediastinal shift. I would have said there is tracheal shift as well, and then there is an opacity.
Okay, it's some sort of collapse.
Good.
Because there is negative mass effect around this lesion. It's not fitting any of the classic collapse. I can see the right heart border. I can see so it's not. Maybe it's a subsegmental. Collapse, so not a lobar.
Can I just stop you there? You did say that the diaphragm is not silhouetted. Now, can you compare the diaphragmatic domes of both sides on the X-ray?
Yes, the medial end of the right diaphragm is silhouetted.
Exactly. So when you compare the dome, then you realize that the diaphragmatic dome is actually silhouetted, isn't it? And it's got a lateral straight margin. And something that we discussed earlier about comparing lung vascularity. Did you compare the lung vascularity on both sides in this case? I know it's a bit dark, X-ray.
It's marginally less on the right side.
It is, isn't it? The hilum is small and the blood vessels are definitely sparse on the right side. So put everything together, and you want to comment. So, you've done very well, actually. You have picked up all the abnormalities, just a bit of fine touch.
Okay, so in such situations, there might be a central or hilar mass as a cause of obstruction. Maybe there is a slight bulge projected over the upper part of the right heart border.
You can ignore that. I think that's
yeah,
sure. So we have to do a bronchoscopy to get a final diagnosis.
Yes.
But the diagnosis I would like you to make is right lower lobe collapse. And what has happened is that the right upper lobe has expanded so much, it's coming and touching part of the diaphragm. Although the collapsed lower lobe, when you look at the collapse on CT, you would understand that when the lung collapses to a severe degree, it just shrinks so small, and then it's still out, just part of the diaphragm. Yeah.
Yes.
So it's right lower lobe collapse, and when lung is collapsed, you do CT scan and then you do bronchoscopy to identify. You can see the airway, the right main bronchus, somewhat very well up until the hilum, which means that it's not obstructed, which will not be, because the obstruction is to the lower lobe bronchus, which you can't see in this X-ray. So if you say you correctly identified all the abnormalities, tracheal shift, mediastinal shift, only bit was that the medial end of diaphragm is actually ciliated. So it's possibly a right lower lobe collapse with hyper-expanded right upper lobe. Okay,
Yes.
good.
Okay, so this is a frontal chest radiograph of a skeletally mature patient. I can see increased vascularity, increased vascular markings, bilateral, symmetrical, maybe slightly more on the right side. I can see density projected over the left hilum. Might be projection.
Okay, can you see Hilar points on both sides?
It's quite obtuse on the right side.
Yeah, it need not be acute. That's fine, as long as the point is obscured. As long as this area is not obscured by a density, you can call it normal. And you're right that the left hilum is a little bit dense, which I would attribute to rotation, and I would suggest ignore that.
All right. So other than increased vascular markings, I'd like to systematically check the film. The right and left heart borders are well defined. Both diaphragmatic copula are well defined. Both in my normal practice, I zoom over the apex, but from what I can see here, I think the right paratracheal stripe is slightly thickened and slightly opaque. This might be attributed to rotation too, but
yeah, I would ignore that. There is no bulge, is there? And that shadow is corresponds to the sternum, and it's concave, so you can ignore that.
All right, so I'll continue checking the bones.
Bones are fine.
All right. So I think projected over the left scapular angle, there is an opacity, rounded opacity.
Very good.
Yeah, and another one retrocardiac. It's a bit medial.
Yeah, not very I think that's that one there. Yeah.
Yes.
Yeah. Those structures close to the spine, I would be a bit more careful before calling that as a lung abnormality. It could be spine. It could be. You do see quite a lot in these areas, and you get confused whether to call it. I would be a bit more cautious on calling something that may be a transverse process bony structure. Anyway, you correctly picked up the left mid lung nodule. Yeah.
Yes.
That was the abnormality to be picked up. And what do you do next now?
So in my normal this patient, I would closely examine the lesion to check if it has any special features. But in my normal practice, this patient will usually get a CT scan,
which I give you now.
So I can see a peripheral subpleural nodule. I think there is a small hypodense core within the lesion. It's a single cut. Hello?
Yeah. That's all that's all that's needed to make the diagnosis.
All right. So, is it a hamartoma? I think there is a spot of fat within the lesion.
Fantastic. Yeah, it did pick up that it's low dense, you can say it's fatty density, isn't it? It does look like fat, because the way, ideally you can measure the CT density, but that can be a bit tricky in the lung because there can be partial voluming. So what you do is you compare the muscle. Yeah, the muscle is the typical rule of thumb soft tissue density structure. So you can see that, okay, the periphery is similar to muscle, but the inner part is fat, subcutaneous fat. So that's a hematoma, fat-containing hematoma. You did very well. You did eventually pick up the chest X-ray finding, asked for CT, and then you did diagnose the hematoma. So fat is diagnostic of a benign condition, which is hematoma. All right.
So this is a zoomed-in view for frontal chest radiograph, showing an extra line parallel to the right heart border, which is hypodense medially. I think this corresponds to dilated esophagus.
You can ignore that.
Okay, so the heart borders are well defined. The right and left hilar are free. I cannot see any skeletal abnormality or...
Bones are fine.
Yeah. I think there might be a small nodule just lateral to the left hilum. Yes.
Fantastic. You did pick it up.
Okay, so
I know you would ask for CT because you already mentioned that.
Yeah.
That's why I gave you CT straight away.
All right. So there is an endobronchial in the left lower lobe bronchus, or one of the segmental bronchi. This would be a differential diagnosis, maybe carcinoid, endobronchial carcinoid, maybe a cancer.
Yeah, very good. So why did you say, not many people, when I showed this X-ray, they didn't make the diagnosis straight away as an endobronchial abnormality, but you did very well, and you did specifically said there is an endobronchial nodule. Why did you say that?
Because if it's an extra bronchial nodule, I would expect it to be pressing or compressing the bronchus because it's closely related to it, and this is not happening.
Exactly. So if it was an extra bronchial abnormality, you would expect the nodule to press on the outer wall of the bronchus, and to narrow the bronchial lumen, isn't it? If something pushes the wall from one side, it will narrow the lumen. But here, the lumen is patent, which means it is arising inside the lumen and growing out. Yeah, that is a very good diagnosis. This is endobronchial abnormality. So when you see a nodule on CT, try to look at the bronchus, and if it's an endobronchial nodule, try to make the diagnosis straight away without, the examiner giving prompts. So the next step would be a bronchoscopy and biopsy, and the differentials in this case, because it's central, endobronchial, carcinoid. Second differential would be?
Cancer, I guess.
Bronchial adenoma, endobronchial metastasis, which is most commonly from melanoma, and so on. So a broad differential of solitary pulmonary nodule, all these headings, granulomatous lesions, malignant lesions, benign tumors, which are adenoma, carcinoid, and hematoma. Hematomas tend to be peripheral, whereas adenomas and carcinoids tend to be central. Infection, rounded pneumonia, hydatid cyst, congenital abnormalities like sequestration, bronchogenic cyst, vascular lesions, including infarct, hematoma, and AVM. These are very broad differentials. There are different features that will point towards each of these differentials, which we would be discussing in the presentation. So endobronchial nodule differentials are, I should have added bronchial adenoma here, carcinoid, hematoma, metastasis, and bronchial adenoma. Okay, next case, please.
So this is a lateral chest radiograph. I can see high density projected over the posterior lower lobe.
Are you talking about this?
Yes, and yeah, the second one.
This one, yeah, okay, yeah, that's good, yeah.
So it's based over maybe the chest wall or the fissure. So in my normal practice, I check the frontal chest X-ray first.
Yeah, very good. Just check this frontal first, and you can see that there is an opacity projected over the spine, just in the lung, and then distally there is further opacity, so probably a mass with distal consolidation. But check the X-ray first. This is the frontal. Does that help?
Yes, it does. It helps for the localization, so it's in the right side.
Yeah.
And
yeah, you can say just there is an opacity in the right lung, and is it obscuring anything? Is it not obscuring anything?
It's not obscuring the right heart border. It's maybe the medial diaphragm a little bit is obscured.
Yeah, so it's not obscuring the right heart border, which means we know from the previous that it is not in the middle lobe.
Yes.
Yeah, good.
So I get a CT.
Fantastic, which is what you're given.
Yes, so it's a heterogeneously enhancing mass lesion, peripheral in the lower lobe, as we localized before.
Yeah.
I can say there is another related large satellite nodule related to it.
Yeah.
Cranially.
So that's the mass, and there is distal consolidation because the mass is causing obstruction. It's pretty straightforward. Okay.
So there is a well-defined mass projected over the right lower zone. It's not obscuring the right heart border. So it's mostly in the right lower lobe.
Yeah. Correct. This is a large solitary pulmonary mass. Differentials of would be broad, quite broad. Yeah, can be lung cancer. This is actually a metastasis, solitary cannonball metastasis to the lung. And the differentials of solitary pulmonary metastasis are sarcoma, melanoma, cancer colon, renal, testis, and breast, of which sarcoma is, I think, more common. And melanoma kind of appears in differentials of quite a lot of stuff, so remember that. And then renal also comes up in differentials. Sarcoma, melanoma, renal would be most common in this instance. And colon and breast are usually multiple nodules than solitary nodules, but then that also comes under the differentials.
So these are, I can see multiple pulmonary nodules. The largest is projected over the heart. There are 3 smaller nodules lateral to this one, maybe, and on the contralateral right.
So the largest nodule is, where did you say the largest nodule was?
The largest is projected over the heart.
Okay, when you say projected over the heart, it can be both sides. So
yeah, I'd say mostly retrocardiac.
Yeah, retrocardiac. Which side, please?
On the left. And there is one projected over the right hemidiaphragm.
Right hemidiaphragm. That's fine. Ignore that. So it's good. You did pick it up. You could have easily said, I can see an opacity in the left retrocardiac region. That's quite an easier way of putting it. Yeah. Okay, that's fine. You have picked it up, and then the X-ray stays there.
Yeah. So there are multiple nodules everywhere, I'd say. So there are 3-4 smaller nodules lateral to the large retrocardiac nodules. There is one in the left upper zone. There are multiple on the right side too.
Okay, so the nodules that you're describing, what is their density?
I would say soft tissue density, maybe a little bit higher.
Yeah, a little bit higher. So there are actually calcifications, and I would ignore that. So the nodules of that size, you're talking about that, isn't it?
Yes.
And some of the nodules there. So nodules of such small size, if they are demonstrable and more dense than a rib, then that means that they are calcific nodules, and not something to worry about.
All right. So there is deformity of the right upper chest wall. Probably I would correlate that with patient history or old film.
Yeah, that's good.
Okay, so
deformity of chest wall can be congenital, can be
traumatic,
can be, and post-op.
Yeah, post-operative maybe.
Yeah, good. So you have a post-operative chest X-ray. Patient has undergone a previous surgery, and then there is now mass. So putting together.
Yes, maybe it's a recurrent metastasis.
Yeah. So patient must have had right upper lobectomy, and then now there is a new nodule, which means it is metastasized to the lung. Yeah. So the idea of FRCR to be exam viva, it's very unlikely in chest X-ray you will have this one single finding. It's often more than one. So if you find one abnormality, look for the other and try to put things together and make a final diagnosis. That's what the examiners expect. Yeah?
Yes.
Good.
Okay, so this is, I can see a large cavitary lesion projected over the right middle zone, medially. I can see a small fluid level within the lesion, and there is a wide... Sorry?
Differentials? Sorry, I missed you there. I can't hear you.
Maybe cavitary granuloma.
Yeah. So there is a cavitating mass with air fluid level. Yeah? Yes. Can you see the air fluid level? Can you see the horizontal level?
Yes.
Good. That's a lateral X-ray showing where will be the location of this abnormality?
So it would be the apical segment of the right lower lobe.
Yeah, apical segment of lower lobe or posterior basal segment of the right upper lobe. Okay. So broad differentials again, infection, neoplastic, vascular, abnormal lung, granuloma, trauma, very broad. I think we'll skip through that fast because we are, a bit short of time. Yeah. So next one.
It's a large mass of high density projected over the right upper zone.
Yeah.
I can see that the underlying rib is not. It's a bit hazy, but I think the underlying rib is abnormal. I think it's taking the axis of the rib, of the anterior rib, I suppose.
You can ignore that. The ribs are fine.
Okay, so it's a well-defined right upper zone nodule. In my norplex, I would get a CT for this lesion. I'm searching for any other abnormalities. The right hilum is slightly...
Ignore hilum.
Okay.
Ignore rest of the X-ray.
Okay, all right. So it's a lung mass that needs further investigations, initially CT scan. But I can see some hypodense or lucent vacuoles related to the upper part of the lesion.
Diagnosis? You did pick up the abnormality. You did pick up the finding that will lead you to the diagnosis. Yeah?
Yeah, there are some. It's a large hamartoma. Maybe it's a large hamartoma. Oh, crescent sign. Okay, it's a crescent sign. Air crescent.
Fantastic. Yeah, air crescent sign. So there is a mass lesion which contains air crescent sign on top. So diagnosis is?
It's an aspergilloma.
Yeah, That's a mycetoma, fungal ball inside a cavity.
Yeah.
Yeah, CT, easy to confirm that on CT. Okay, but then you should get your eyes trained to pick up air crescent sign in nodules and mass lesions. Fungal ball, most commonly in TB cavity. It can happen in sarcoid cavities, cystic bronchiectasis cavities, bronchogenic cyst, and air crescent sign is dependent fungal ball inside the cavity with the rim of air above.
Okay, so I can see that the left hemidiaphragm is obscured by a horizontal fluid level. It's not a fluid level, it's just obscured. There is a small effusion.
I can see the costophrenic angle here, so I would ignore that. There is a little opacity there. You can mention that. Not all chest X-rays would be 100% perfect. So examiner would say ignore that. So I'm telling ignore that. There's probably a little consolidation there. That's fine. It's fine for you to pick it up. You can say there is a small opacity there. That's fine.
Okay,
ignore that.
Okay. So I'm systematically examining the film. The heart. I can see a retrocardiac opacity.
Fantastic. Left retrocardiac opacity again. I'm hoping the rest of the candidates attending this exam, the session, are able to identify that. So it's quite behind the right heart. It's quite loosened. You can see the lung there, rib, where there is something sitting there. Usually you should expect the lower lobe pulmonary artery and the veins to see there, but you correctly identify the left retrocardiac opacity. Again, you can see the retrocardiac density. I'm just showing the lateral X-ray to get your eyes used to lateral X-rays. So can you see that? The opacity projected over the spine in the posterior lung. So I'll give you CT now.
Okay, so on CT, the lesion is iso to hypodense with a vessel directly arising from the abdominal aorta feeding the lesion. So I would say my diagnosis is AVM versus sequestration.
Sorry, what was the first differential?
AVM versus sequestration.
What is AVM?
Arteriovenous malformation versus sequestration.
Okay. So yeah, I don't know. I don't think AVMs are supplied by pulmonary artery. Yeah. Lung AVMs are supplied by pulmonary artery. The only condition in which systemic blood supply arises for an abnormality in the lung is your second diagnosis, that is sequestration. Yeah.
All right.
It's good you identified the descending thoracic aorta giving an artery to the pulmonary nodule, and it's a sequestration. All these things, theory about sequestration, you know already. You have done the 2A. I would just recap the intra-lobar sequestration, as called systemic arterial supply, communicates with tracheobronchial tree and shares the pleural covering with the rest of the lung. And intralobar sequestration, its venous drainage is into pulmonary veins, whereas extralobar sequestration has systemic arterial supply and systemic venous supply. Okay, and usually they present as infections under the age of 20 years.
So this is a lateral chest radiograph. I can see that the lower thoracic vertebral density is not as low as I would expect.
Fantastic. Yeah. And like you said before, you can ask for?
Yeah, for the frontal projection, please. Or
instead
CT.
of frontal, I give you CT.
Okay, so I can see in the CT there is pleural-based soft tissue dense lesion with linear markings radiating from the lesion towards the lung. So this is unfolded lung?
Yeah, folded lung, yeah.
Folded lung.
Yeah, that's all right. You got the diagnosis. Rounded atelectasis or folded lung which is actually the features will be crowding of bronchovascular structures from the mass towards the hilum, adjacent pleural thickening. There will be some volume loss and displacement of the fissures. The differentials are most common asbestos exposure. Rather, nowadays, the most common will be post-coronary bypass surgery, TB, pericarditis after MI called Dressler syndrome, and trauma.
So I can see two small dense nodules or project over the left upper zone. The right, yeah, yes.
Very good.
The right hilum is also.
Ignore the right hilum.
Okay. So
ignore the rest of X-ray.
All right. So they are dense nodules. I suspect that they are calcified, but I'd like to confirm this by CT. Maybe they are calcified granulomas, maybe hamartomas.
Yeah. What about the pulmonary veins in the upper hilum on both sides? Are they similar size or are they kind of dissimilar in size?
Yeah, they are much larger on the left side.
Good.
Yeah, so maybe it's an AVM.
Very good. So I'll give you CT then.
Okay, so I can see a tortuous, long, dilated vessel arising around the opacity.
Yeah.
Down to the hilum.
Yeah, yeah. So pulmonary AVM, the chest X-ray abnormalities would be a nodule with dilated blood vessels. So look for, train your eyes to identify vascular dilatation, vascular structures on X-ray. I think I will change candidate now. Can candidate 3, thank you, number 2, can you mute yourself?
Thank you very much.
Thank you. Candidate 3, can you raise hand and unmute, please? Candidate 3, can you raise hand, please?
Hi, can you hear me?
Yeah, I can hear you. Good. So do you want to start with this case?
Yeah, it's a frontal chest radiograph in erect position of a vascularly mature patient demonstrating bilateral diffuse predominant perihilar, but then going to the periphery of ossification. With probably some vascular upper lobe divergence, especially on the left side. Heart is of normal size. Visualized right costophrenic angle is not showing any perfusion. Trachea central no retrocardiac opacity. The hilas are fine as well.
Some examiners can be sometimes nasty, you know. Anybody can say there is some diffuse abnormality in this. But a 2B candidate is expected to go a bit more further, identify the pattern, what's happening.
So the diffuse, I think it's alveolar opacity, I would rather say.
Ah, good, good. So you're thinking in the right direction.
Yeah.
That's good. So when you see an opacity, you tend to think, oh, is it alveolar, which means inside the lung air spaces, or is it interstitial, which means along the margins of the interstitium around the alveolar spaces. That's how you should think. So you did initiate that thought, which is good. Now, can you tell me, is this more likely interstitial, or is it alveolar acinar opacities?
I think it's more alveolar, to be honest, because it's projected as very diffuse, fluffy shadows. There are also some increased interstitial markings on both sides, but the pattern is more.
If you see more and more X-rays, you'll get your eyes used to differentiating acinar shadows and interstitial shadows. So acinar shadows, I will be elaborating on this later. Acinar shadows, to this degree, if they happen, they'll coalesce together, and they will be like nodules, more like nodules. Where here, what's happening is, if you carefully, it's more reticulations. Can you see that? Crisscrossing lines, crisscrossing lines, crisscrossing lines. Not many nodules, crisscrossing lines. There are some nodules, centrilobular, but that they are small. It's more crisscrossing lines. Suggestive of?
Yeah, interstitial pulmonary edema.
Interstitial pulmonary edema is a differential, but there is something else. Yeah, that's a differential of reticular shadows.
Fibrosis can also show fine and coarse reticular shadows.
Beg your pardon? I didn't hear that. Sorry.
Lung fibrosis can also have interstitial increased interstitial lung markings, fine and coarse. Carcinomatosis can also present, but mainly it's unilateral, but it can be bilateral.
Okay, carcinomatosis, lymphangitis carcinomatosis can be bilateral. So how about the hilum here?
Hilum is bulky.
Exactly. So there is hilar lymphadenopathy, there is bilateral reticulations. Differentials?
So cancer, underlying cancer with bilateral carcinomatosis.
Lymphangitis carcinomatosa. Yeah?
Lymphoma.
So that, lymphoma, yeah.
Again, I will keep interstitial pulmonary edema, although there's no sign to suggest cardiac enlargement or perfusion.
Will there be hilar lymphadenopathy in interstitial pulmonary edema?
No. Fibrosis can also give you a hilar lymphadenopathy sometimes, but there's no volume loss here.
Right. It's very unusual for UIP or idiopathic pulmonary fibrosis to have this degree of bilateral bulky hilar lymphadenopathy. You can have mild enlargement of nodes, mediastinal nodes and hilar nodes in IPF as a part of inflammatory process, but that's quite small and you will not see this degree of bulky hilar lymphadenopathy.
Sarcoidosis can also give you...
yeah, so those three are the most likely differentials. Bulky hilum, bilateral reticular opacities, lymphangitis carcinomatosa, lymphoma, sarcoidosis. And you can have silicosis, but then you'll see nodules more than that. Okay.
Sure.
So this is actually lymphangitis carcinomatosa. So HRCT showing thickened septations everywhere. Those are the thickened walls of the secondary pulmonary lobule, and the thickening is a little bit nodular. Lymphangitis carcinomatosa. My colleague will be elaborating more on interstitial patterns in her chest advanced session later. So just a quickly differential reticular pattern, IPF, which is interstitial pulmonary fibrosis, rheumatoid arthritis, collagen soft tissue disorders, asbestosis, sarcoid. I won't elaborate on these broad differentials because we are short of time. It's better to put differentials into small groups rather than addressing it broadly based on other abnormalities. For example, in the previous case, there was no cardiomegaly, so it's not cardiogenic pulmonary edema. There was hilar lymphadenopathy, again, a point against pulmonary edema. So, narrow it down to lymphoid, sarcoid, malignancy, etc., rather than a broad differential across the spectrum. Again, hilar enlargement, broad differentials, keep this in mind. Most common sarcoidosis, lymphangitis, lymphoma, and silicosis. Next one.
It's a frontal chest radiograph. There is some opacity of the left lower lobe, which is more, I would say, alveolar based because of the fluffy nodular shadowing.
Yeah, that's good. So I would describe it as a kind of ground glass opacity. This is what you're referring to, isn't it?
Yeah.
Yeah, good. That's it. I mean, there are no other diagnostic features in this X-ray, so I'll give you CT.
CT is demonstrating some ground glass nodularity of upper lobe and predominantly left lower lobe. There's also consolidation. So the appearances are, the differential here would be eosinophilic pneumonitis, which can also give you some ground glass nodularity and...
Which eosinophilic pneumonitis will appear like this?
EAA can give you...
Sorry?
Allergic eosinophilic.
Allergic eosinophilitis. Okay. That's one of the differentials, okay.
Other differential here could be, since it's patchy and ground glass. I would be keen to see lymph nodes here as well, just to see.
Okay, there were no lymph nodes in this case. There is another abnormality that I want you to pick up in this X-ray.
There's consolidation in the left lower lobe.
Can you see my arrow?
Yeah. It's an air bronchogram through it, subpleural linear lucencies.
So what do these refer to? Those, what are those? I did mention it in the.
I was thinking of air bronchogram through the consolidation.
No, where my arrow is. In the left lung.
Yeah. Subpleural shadowing. Linear.
Yeah. So there are linear shadows. Yeah, linear subpleural shadows. Linear shadows in the subpleural area, which forms the wall of the secondary pulmonary lobule, which means there is what?
Sequestration.
Right. I mean, this is interstitial thickening. Yeah. Okay. So there is ground glass opacity, which is an alveolar acinar process. In addition, there is interstitial thickening, as you can see, thickening of the interlobular pulmonary septa. When these things both happen together, that pattern is called? That pattern is called crazy paving. Okay. So differentials of ground glass opacifications are hazy increase in the definition of ground glass opacification is hazy increase in lung density without obscuring the vessels and bronchi, whereas a consolidation will obscure the blood vessels. You can see the bronchi through the consolidation, that is called a bronchogram. But in ground glass, you can see the vessels as well as the bronchus. It's quite non-specific. The differentials are quite wide. It can be partial airspace filling infiltrates. It can be interstitial infiltrates. It can be combined airspace and interstitial infiltrates. It can happen in collapses and increased capillary blood volume. The previous case had crazy paving, thickening as well as interstitial thickening as well as ground glass, and we will come to differentials of crazy paving later. That was a case of adenocarcinoma of the lung, like bronchoalveolar carcinoma, which is nowadays called diffusely infiltrating adenocarcinoma. Right, all these differentials, which we will, so that the case showed was diffuse adenocarcinoma, which was formerly called bronchoalveolar cell carcinoma. Next, please.
So frontal chest radiograph demonstrating.
Is it chest radiograph? Are you able to see the costophrenic?
No, it's a lumbar spine AP film demonstrating abnormality in the left lung.
Good.
Which is linear lucencies through the opacified and hypovolemic left lung.
Yeah. So in your practice, when you see a lung abnormality on a spine X-ray, what would you do?
I would request, or if the patient's on the table, I would do the complete chest X-ray.
Fantastic. I give you chest X-ray then.
There's almost sparing the left apices is almost white out of the left lung, with I think the raised left hemidiaphragm as well. Although I can see the trachea is relatively central. On the trachea is okay. It's pulled towards the right, pulled towards the left side. Then I think there's mediastinal shifting as well because the heart's
very good. Very good. So what's happening?
So there's a collapse going on in the predominantly left lower lobe and the probably lingula as well. There's also, I think, AP window is obscured as well, whether it's because of the mass sitting there or because there's some lymphadenopathy or collapse.
Yeah. So what do you do next?
So there's probably CT scan is the next step.
Yeah, I'll give you CT.
I can see there is a endobronchial lesion.
Very good. You did pick up endobronchial. Fantastic. Yeah.
And resulting in the collapse of the lung, left upper lobe. This could be an endobronchial tumor, carcinoid, or endobronchial adenoma.
Yeah. So everything on in an exam setting, everything that is displayed carry some value and meaning. So here I have put CT density measurements on the CT.
Okay. So it's a negative. So it's fat density.
Yeah.
So hematoma can happen as well. Endobronchial hematoma.
Hematoma, yeah.
Hematoma, yeah. Which can have negative density.
Yeah.
So
this is an unusual case of endobronchial lipoma, which is very good for the patient. Better prognosis than an endobronchial carcinoid. Endobronchial, most common differential of an endobronchial abnormality, as we said, is carcinoid. But this was a rare case of endobronchial lipoma. Very good for the patient. You did make the diagnosis. Very good. We'll go to the next one. So, in this phase, I would like to just briefly discuss differentials of increased density of a hemithorax. We all struggle when you find increased density as general radiologists. Oh, what's happening? That is quite white. But if you look at Chapman, it's quite simple. If you see increased density of a hemithorax, then you look for mediastinal shift away towards or no shift. Okay. If there is no shift, it's consolidation, and it can be pleural effusion with not much expansion, and it can be mesothelioma where it may be shifted to the same side, but then if there is effusion, it may go back to the unshifted side. With shift away from the dense side, it's large effusion or diaphragmatic hernia. With shift towards the dense side, it's most commonly collapse, which is this case. It can be agenesis, hypoplasia, pneumonectomy, lymphangitis, mesothelioma, especially if there is volume loss. So when you find large density, don't panic, look for mediastinal shift. And if there is shift towards, most commonly it's collapse, which is the right diagnosis which you correctly made here.
This is a frontal chest radiograph with the white out left lung. I can see there is some mediastinal shift towards the left side as the trachea is deviated towards the left side, and the heart is also deviated towards the left side.
Yeah.
I'm just wondering whether there was a history of any previous surgery. I cannot see the clips there.
Good. You are thinking in the right direction. Yeah.
There's also an opacity projected over the left hemidiaphragm. Right hemidiaphragm, and also medial side of the lateral side of the medial aspect of right.
So what's happening here? So we discussed a totally opaque hemithorax is always abnormal, and the differentials are pulmonary collapse, pulmonary agenesis, pneumonectomy, but you didn't find any clips. So this is most probably
collapsed, complete lung collapse.
And when you find a collapse with a mass on the opposite side, you would think of
a tumor obstructing that with the metastatic lesion on the other side.
Yeah, it could be a lung primary obstructing the cancer here, and then causing a metastatic nodule in the other side, which is what you see on CT scan here. CT scan, I'm showing you CT scan only because to differentiate the collapsed lung from the mass. So the collapsed lung is always uniformly enhancing. Can you see that?
Yeah.
So that's the collapsed lung, and the non-collapsed mass lesion. The mass lesion is actually a soft tissue mass, which is less enhancing on a post-contrast CT. It has got a lot of blood vessels and necrosis going on. We'll skip this and go to this. Yeah.
So there's a frontal chest radiograph demonstrating for a few abnormalities. The main is the large irregular opacity projected over the right lower zone. I think they are the coalescent nodules because I can see the cluster of nodules, I think, will coalesce together. There's also some nodularity.
Ignore the nodules.
So there is a large opaque mass in the right lower zone. The differential here could be because I can see there is a cylinder maintained. It's not projecting over the medial lobe of the right heart or the diaphragm. So this could be primary lung cancer or lung mass.
Yeah, Okay, you have described the chest findings, okay, lung findings. Now, can you go outside the lung?
Yeah,
There is something else that I want you to pick up.
Yeah, there is.
And it's not in the bones. Bones are also fine. Not lung, not mediastinum, not bones.
There is there are clips on the projected on the left, below the left hemidiaphragm. I can't see the breast shadow on the left side.
Yeah, this is a man.
That's a man. Okay. So there must be some surgery done on the left side. I'm not sure what kind of surgery it's performed on the patient before.
Right. Are you talking about this one?
Yeah.
So what is this actually? What is?
It's a stent. I think it's a stent.
Very good. It's a stent from where?
I think it's probably esophagus or some.
Very good. So what has happened? Esophagus is not here usually. So what has happened?
I think it's the descent or migrated stent.
Migrated stent. Yeah. So this is a cancer esophagus. The stent has migrated, and when stent migrates, they don't know the stent has migrated, do they? Patients don't know that. They're happily having consuming their normal food, enjoying their breakfast, dinner, lunch, keep on eating in a state of migrated stent with cancer, and all the food they eat going to the lung and result in
pneumonia, aspiration pneumonia.
Aspiration pneumonia. So the learning point is that look at the periphery of the radiograph, look at other abnormalities, and then put things together. That's how 2B works. It's never one single finding and diagnosis. Yeah? Are you with me?
Yeah.
Good.
It's a frontal chest radiograph demonstrating a fracture in the mid-clavicle of the right side. The bones are very sclerosed throughout, very dense. So this looks like a pathological fracture of the right clavicle. There are multiple lung nodules on either side. I'm wondering whether the patient has a history of any prostate cancer. And these looks like okay. So there's a breast mass on the left side. So this is a female patient with the metastatic bone and lung lesions with the pathological fracture of the right clavicle.
Where is the breast on right side?
Sorry?
Where is the breast on right side?
History of previous mastectomy.
Good.
And you
don't diagnose a breast mass on a chest X-ray. You can't, because breast mass lesion is inside the breast, and unlike a lung mass or lung nodule, there is no air surrounding a nodule or mass in the breast to make that diagnosis on chest X-ray. Yeah, you can see soft tissue. That's actually the breast rotated outside. Yeah, so that's fine. You know, when you're in exam setting, even if you make a little errors, don't worry. Just say that it's because it's chest X-ray, it's unlikely to be a breast mass. It's just the breast rotated to one side. Yeah. Sure. So you're diagnosed right mastectomy with widespread bony lung metastasis and pathological fracture in the clavicle.
This is the frontal chest radiograph which is demonstrating bilateral pulmonary nodule. There's also I think the right hilar looked a bit bulky to me, but the normal V shape is maintained. The vascular, the hilar inlet is maintained. I'm just looking at the right apex. Yeah, this looks quite bulky to me. Parahilar right-sided. So I'm just wondering whether the patient has got a right hilar mass with a metastatic pulmonary nodule. There's also left.
So I'm running short of time, so I'm going to.
Yeah. Okay.
The lung here, you can see that is bordering the mediastinal borders, whereas here you can see an opacity. Yeah. Good. So you should try teach your eyes to pick up these abnormalities, and there is right hilar and tracheobronchial lymphadenopathy, and there is a nodule on the left side. Yeah. So that's lung cancer that is metastasized to mediastinum and hilum.
Again, this frontal chest radiograph with the left-sided soft tissue opacity subpleural probably position, very smooth contoured and merging with the chest
Very
wall.
good, very good. I would have described it as extrapleural rather than subpleural. Yeah.
Yeah. This chest probably chest wall.
Yeah. Yeah.
on the
It's
lung.
not in, which you correctly picked up. Why did you say it's not in the lung?
It's the lung is not the lung margins are quite normal. I cannot see any atelectated shadow, and it's merging with the soft tissue of the chest wall.
Yeah, very good. So it's got a broad base to the chest wall, and you can't see the lateral margin. If it was inside the lung, some lateral margin you would have been able to perceive. Isn't that right? Yeah?
Yeah.
Yeah, good. So there is something else that it clinched the diagnosis here.
Just looking at the bones, the rib on the left side, overlying rib looks irregular, and I cannot see at the border of the rib. So this is a mass involving the either involving the rib or arising from the rib and expanding on the chest wall.
Very good. Yeah. So which rib are we talking about?
The posterior rib on the 1, 2, 3, 4, 5, 6, 7, 8th rib on the posterior.
Okay.
Rib.
So are you talking about this one? You can't see the. So that rib was destroyed. It forms a soft tissue mass. Good. So you have picked up the most obvious abnormality and reached the correct diagnosis on that. That's a rib lesion outside the pleura and outside the lung. There is something else in the edge of the radiograph that it clinched the diagnosis.
So on the left side,
it's on the right side. I'm giving too many clues because we are short of time.
There are some clips on the right axillary.
Very good.
So patient may have as a patient, obviously I don't know the patient. I think patient female patient may have right-sided breast surgery or with now presenting with the metastatic lesion.
Such extensive axillary clips happens when there is previous axillary clearance. Yeah. Axillary clearance are commonly performed in breast cancer with positive axillary lymph node metastasis. Okay, this need not be a female. Men also can get cancer breast, but the clue is that there are extensive axillary clips suggestive of previous surgery. So this is most likely a metastasis. Yeah.
So it's a frontal radiograph of the right shoulder. The shoulder joint is itself normally gleaming. Shoulder
is fine.
Yeah. There's excuse me. There's a sclerosis of the clavicle.
Ignore that.
The lucency of the medial of the clavicle.
Ignore that.
The lung appears. There is some. There's opacity of the right apex.
Very good. Yeah, and
there is also some soft tissue swelling around.
Can you see the third
rib destruction is accompanying?
Very good, very good. So there is rib destruction there.
So this is like a Pankos tumor.
Probably a Pankos tumor or a primary rib lesion. Yeah. So actually, this is the same patient with the rib lesion. Yeah. And
there is a previous axillary clearance.
Very good.
So metastatic lesion.
Okay. So that ends the session. We'll take a short break and then we'll continue. Okay. So when we continue, sorry, what was your candidate number?
3.
Number 3. So we'll start with number 4 now. Thank you.
Thank you very much. Thank you.
Now it comes.
Yeah, I can see it now.
Yeah. Look, I can see I've logged in 2 sources on my phone as well as my laptop. I could not see the X-ray, but now I can. So yeah, do you want to go?
Yes, I've got an AP rect radiograph and then skeletal image operation.
Your voice is a bit faint. I'm not able to clearly.
Yeah, can you hear me now?
Yeah, that's better.
So I've got an AP rect radiograph and a skeletal image operation in which I can see there are bilateral appear to be cavitating lesions because they're loosened with a dense margin in the left lower lobe, and then on the right I can see there is obliteration of the right lateral hemidiaphragm, and again what appears to be like a cavitating lesion in the right lower lobe. The upper lung zones appear unremarkable. There's no hilar lymphadenopathy, and the imaged bones are unremarkable. So I've got multiple cavitating lesions, and my differentials would be, depending on the clinical history, it could be secondary to Wegener's granulomatosis, it could be secondary to...
Yeah, the diagnosis is Wegener's granulomatosis. So you did mention Wegener's first, which is brilliant, because as you can see in the X-ray on the right side, there is a little bit of collapse, a little bit of chronic scarring process. So this is not an acute thing. An acute X-ray would have been much more pristine with multiple cavities. So which means it's been going on for some time, which makes Wegener's the more likely diagnosis in this, which you correctly identified. That's good. So differentials of cavities, the broad differentials, because of lack of time, I won't go through the differentials today.
So again, I've got a frontal radiograph in which I can see in the right lobe there is some opacification, and it touches the horizontal fissure. And again, it appears like a large, it's peripherally based airspace opacification, and with some cavitation as well peripherally, more medially. The left lung is clear and there's no mediastinal shift, so there's no mass effect, and it's obscuring. And then 12 days later, I can see that there's a peripheral airspace opacification in the left lung. So we've got fleeting airspace opacification, which would be in keeping with the chronic eosinophilic pneumonia.
Yeah, very good.
Loughlins, yeah.
Yeah, you're nearly there. It's migrating consolidation, differentials, organizing pneumonia, recurrent aspirations, pulmonary eosinophilia, pulmonary hemorrhage, vasculitis, infarcts, alveolar protein. This is very broad. I don't think it's useful, but given in Chapman. The case here is actually low flow syndrome, simple pulmonary eosinophilia, which is fleeting peripheral airspace consolidations with little symptoms, marked eosinophilia, and it's usually a reaction to parasitic infestation or drug reactions, NSAIDs and antibiotics and ACE inhibitors. Yeah, so it looks like, yeah, I have this is what I wanted to. So parasitic infestation is the most common cause of low flow syndrome worldwide. But remember that these kind of appearance can be drug related, and recreational illicit drugs can cause them too.
So
I've
again,
given you history. Yeah, I would given you history as well.
So again, I've got a frontal radiograph with a history of chronic low-grade fever and cough. So I can see there's upper zone predominant peripheral airspace opacification, sparing the lung bases, no hilar or mediastinal lymphadenopathy, no mediastinal shift. So, and it's a history of 3 months. So I'm thinking about cryptogenic organizing pneumonia, and there's a dysphonia, so hypersensitivity pneumonitis would be in my differentials as well. And
yeah, hypersensitivity pneumonitis is more basal and mid zones.
And
yeah, but right thinking, correct thinking. So this is chronic pulmonary eosinophilia. I don't think we can make that diagnosis entirely by the X-ray. It requires bronchoalveolar lavage. So this, I don't think this might come for exam, but just for completion, this is a sign that I wanted to identify: reverse batwing or reverse pulmonary edema appearance, as shown in the X-ray, is kind of not typical, but quite contributory to make the diagnosis of chronic pulmonary eosinophilia. And after steroid treatment, they completely disappear. Next one.
So again, on this frontal radiograph, I can see peripheral airspace opacification there. predominantly involving the lower zones. These appear like fluffy airspace opacities.
Very
So
good, very good.
the diagnosis for this would be a hypersensitivity pneumonitis, and I'd confirm this with an 8.
That's 100% correct. I don't think anybody has diagnosed this in the last 10 years. I have presented the first time hypersensitivity pneumonitis. So I hope everybody is listening to candidate number 4, especially with regard to pattern identification. The way she has described, once an abnormality is picked up, looked at the distribution of the abnormality in the lung. So previously she identified bases, she mentioned bases as paired. That's really very good. Examiners will be very happy to hear that. That means you're thinking in the right direction to put these abnormalities in the right diagnosis. So here she correctly identified the bases are more involved and fluffy airspace abnormalities, which are a diffuse, suggestive of a diffuse lung airspace process more in the bases, and it's hypersensitivity, acute hypersensitivity pneumonitis. What other differential could you give in this scenario?
So it's quite bilateral and symmetrical.
Yeah.
Upper lobes are spared.
Yeah. I mean, there isn't, yeah, it's not typical.
Yeah.
But if there is no exposure, hypersensitivity pneumonia, there will be usually an exposure to an antigen, an allergen. So suppose the examiners, you could have put, you could have elaborated a bit more, saying that you would look for recent exposure to any particular allergen, like cleaning a bird cage or a new parasite in the house or a new kind of cheese, etc. Thinking of hypersensitivity pneumonitis. And if the examiner says, no, there is no history of exposure to allergen, what are the differentials? Since you are going so well, what are the differentials would you consider?
So TB doesn't involve the brain. It wouldn't be.
Especially in the current scenario.
I don't know whether COP, cryptogenic organizing pneumonia, can involve that as well. And they're also ground glass with a surrounding hair.
Good.
That would be one. And then aspiration tends to go to lower lobes, but this is more bilateral, so would be less like.
Atypical pneumonias, PCP, although PCP is a bit more central than basal. If the examiner is persisting, you can give atypical pneumonias, viral pneumonias, also give vague opacities of this kind. COVID will be extensively elaborated in the next session by the chest first, my chest colleague. So this is acute hypersensitivity pneumonitis, bilateral airspace opacities, which are actually inflammatory exudate and edema, mid and low lobes. Effusion and lymphadenopathy are rare, and symptoms will resolve if the exposure is discontinued. Broad differential, most common is cleaning bird cage and so on. Next case.
So I've got a frontal radiograph and the trachea has central normal heart size and mediastinal contours. I can see what appears to be like multiple cystic lesions scattered throughout both lungs. They're quite lucent and tiny. So I'm thinking whether this patient's got an underlying cystic lung disease and has got...
Is it cystic reticular shadows or is it more nodules?
Yeah, I think it's more nodules now. I think it becomes fuzzy in there. So I've got tiny nodules scattered throughout both lungs, predominantly involving the mid and lower zones. And
excellent. So immediately after picking up the abnormality, you went into distribution. Yes. Is it involving the upper lungs?
No, it's sparing the apices.
No, it's sparing the apices. And as far as you can see, does it involve the bases? Maybe a little bit, but not as much as the mid lung, isn't it?
Predominantly symmetrical mid zone involved.
Mid zone. So there is sparing of the costophrenic angle. There is sparing of the apices. So differentials?
So got tiny. Differentials could include, so this could be miliary nodule secondary to TB. We can
What's the distribution of miliary nodules? Does it spare the apices and bases?
No, it doesn't spare the apices.
It doesn't, yeah. So when you say spare the apices and bases, you should not say miliary at all.
Yeah.
Good. I mean, a little slip of tongue, don't worry. You can retract the statement, when you think later, say that, okay, the miliary does not spare, the miliary is uniform, so I don't think miliary would be a differential in this, and go on to other differentials.
And again, sarcoid won't be in my differential. I can't see hilar lymphadenopathy, and again, it tries to and middle lobe distribution. Other things would be silicosis tends to have nodules, but again, there's no calcified lymph nodes that I can see. LCH can present initially as nodules which spare the bases, and then then they change into...
Very good. Yeah, so very good.
My top differential, looking at the distribution, because they spare the lung bases and the CT angles. I'd like to compare it with any previous radiograph and then confirm it within...
The previous radiograph was the previous case.
Sorry?
The previous radiograph was the previous case. It's the same patient's X-ray. The acute hypersensitivity pneumonitis.
Okay. We've gone on to develop... So this is a different presentation depending on the stage: acute, subacute, and chronic.
Very good. This is subacute. Yeah, this is subacute.
Yeah.
Okay. So just to highlight the nodules, you can see small nodules in the lung. Are you able to see the larger screen?
Yeah, now I can see them.
Yeah. So the large, small nodules in the lung, which are not. The purpose of projecting the larger is to get your eyes used to picking up nodules in the lung. So these are not vascular structures.
Yeah.
Yeah, that's how you identify the nodules. And on CT, the same thing. There are multiple centrilobular nodules in a non-uniform distribution. If it was uniform distribution, you would have thought about miliary TB. This is non-uniform. And this is subacute hypersensitivity pneumonitis. Okay, bilateral perihilar small nodules and ground glass densities. On HRCT, 1 to 3 millimeter centrilobular nodules and ground glass opacities in mid-lung, sparing apices and bases. So DD for nodules in mid-zones, you picked up almost everything. Subacute hypersensitivity pneumonitis, sarcoid. Sarcoid can present with no hilar lymphadenopathy, and then silicosis, cold workers pneumoconiosis, and LCH, Langerhans histiocytosis. These are the differentials of mid-zone nodules, which you mentioned almost all of them. You also said that you would not consider sarcoids first because there is no lymphadenopathy, but sarcoid can happen without lymphadenopathy as well. So are we good on this? Nodules, differentials, yeah? Good. Next case.
So I've got a HRCT and probably taken in the inspiratory phase, on which I can see there is a bilateral, subpleural, and perilymphatic cystic lung change, and predominantly involving the peripheries. And there's also associated small centrilobular...
What's the name for this appearance?
It's honeycombing.
It is honeycomb. Yeah, it does look like a honeybee's honeycomb, if you have ever seen one, which is suggestive of?
So it is suggestive of a UIP pattern of interstitial lung disease.
And distribution now?
So they have an apical basal gradient, so more prominent in the upper and than compared to the lower.
Yeah, in this condition, it's more prominent in the upper. So diagnosis?
So diagnosis would be UIP.
What is the distribution of UIP? Upper or lower?
Oh, I think it's more upper. Apical.
No, UIP is lower. So this is actually chronic extrinsic allergic alveolitis. That's the condition that causes upper lobe fibrosis. Yeah. So broad differences of honeycomb lung, collagen vascular disorders, which are basal, chronic hypersensitivity pneumonitis, which is upper lobe. Yeah. Sarcoid, sparing apices, pneumoconiosis, which is similar to asbestosis, cystic bronchiectasis, drugs, LCH, LAM. This is a very broad differential of honeycomb lung. So the previous case was chronic extrinsic allergic alveolitis, because of the upper lung distribution. UIP is lower lung distribution. Yeah, is that okay? Are you okay with that? Are you clear about that?
Yes, no, I'm clear.
Yeah, very good. I think that was probably just a slip of tongue. So I think with this case, we'll do one more case for you, and then we'll move to the other person. Yeah. Good. Do you want to?
So again, it's a frontal radiograph, normal heart size and mediastinal contours, tracheus central, both diaphragms are distinct, and I can see bilateral nodules. They look nodular.
Are they nodules or are they reticulations?
At one point, they look like cystic lungs, and I think I'm just looking at the dens. So I think there are multiple cystic areas scattered throughout both.
Very good, very good. Yeah, so just for the benefit of everybody, multiple cystic spaces.
And I can see they're involving
you can also describe them as multiple reticular opacities. Yeah. So a lot of crisscrossing lines. Yeah. Very good, very good, very good. So what about the lung volume in this case?
So
preserved, lost, expanded.
The lung volume isn't lost. Because
of diaphragm.
Oh, there's flattening. Normally the right should be slightly higher. There's flattening, so there's hyperexpansion of the lungs.
Reticulation with hyperexpansion.
So reticulation with hyperexpansion and a cystic lung disease. I think LCH and LAM.
Yeah, LCH is one, more common.
But LAM...
In a lady, can you see the breast shadows? LAM, very good. Yeah, so that's a HRCT showing rather uniform cystic air spaces throughout the lung. Yeah? This is typical for LAM. In LCH, there will be cystic spaces, but the cystic spaces are non-uniform. So this is pretty characteristic for LAM, lymphangiomyomatosis. So LAM, reticulations with normal or increased lung volume, exclusively women of reproductive age group. They can present with recurrent pneumothorax, chylous effusion, and Hilar or retrocortical lymphadenopathy may be associated. These are the differentials of reticulations with normal or increased lung volume. LAM, emphysema, we'll go through emphysema in detail later. Neurofibromatosis, LCH, and TS, which is pathologically identical to LAM. Can the next person, number 5, is it number 5 next?
Yes, number 5 is next.
Can number 5 has raised hand. So number 4, can you mute yourself?
Yep, thank you.
Thank you, you did very well. Brilliant. So is that number 5? Yeah, your X-ray is ready for you.
Okay, so frontal chest X-ray, I can see some emphysematous changes in the upper zones. The lung volumes are largely maintained. No focal lung lesions, no pleural effusions. The pattern of upper zone emphysema changes, I would be thinking along background emphysema, COPD. Or in a young patient, also thinking along
I'm giving clue.
X-ray sleep slightly. So there's some reticulonodular shadowing at the peripheries, is it? And some cystic changes as well.
Are they reticular or are they more nodules?
They're more nodules.
Very good. So get your eyes used to identifying nodules, separating them out from the vascular structures. Yeah. So they are not vascular structures because they're too far wide away for such big structures to be blood vessels. So and it's not, there are some crisscrossing lines, but extensively when nodules stay together, it can appear like crisscrossing, which is fine. So if you say reticulonodular together, that's okay, but mainly it's more nodules than reticulations and cystic spaces. Yeah, can you see
I can appreciate it better now, actually. Yeah.
nodules now? Yeah, in the bigger picture. So, do you want to give differentials for this?
So there's like multifocal nodules with no significant predisposition. So I would be thinking of random nodules, metastases, sarcoid.
So again, like the previous candidate very well did, when you find nodules, what's the next thing that you could do to help to arrive at a differential?
Check the distribution.
Distribution. Are the costophrenic angles involved?
No.
No. Are the apices involved?
No.
No. So it's predominantly mid-lung nodules, aren't they?
Yeah.
So they're not miliary TB?
No, so it would be sarcoid and LCH as my primary two differential in the mid-zone.
Yeah, sarcoid, the previous differential, sarcoid, LCH, subacute hypersensitivity pneumonitis, silicosis.
Sure, yeah.
Yeah. So that's HRCT showing multiple central lobular nodules. So this is actually LCH. Briefly about LCH, equal gender ratio. There will be history of smoking. Spares the bases. They become nodules will be first, and then they become cystic. Cysts are irregular and non-uniform. No pleural effusions. Lung volumes are normal or increased, and end stages fibrosis and honeycombing. So that's another case of LCH. So multiple nodules. Again, just to how to identify nodules. Can you see the small nodules?
Yeah.
Yeah. So look for these. Get your eyes used to seeing them and identify them, and distinguishing them from vascular structures.
Sure.
This is again LCH. Here the nodules have cavitated and they have formed multiple cystic spaces. Yeah. The cysts are not emphysema because they have a clear wall, and there is no central dot. Can you see inside any central dot?
No.
They don't have a central dot because they are not centrilobular emphysema. They are pulmonary cysts and they are non-uniform, which is suggestive of LCH than LAM.
Yeah.
So pulmonary cysts can be post-infective. Commonly we have learned that staph infection can develop pulmonary cysts, and PCP is quite common, post-traumatic congenital in CCAM or intrapulmonary bronchogenic cyst, neoplasm, especially after treatment of metastasis, and epithelioid sarcoma metastasis, which you may not ever see in your life, analyzing granuloma. And this is the most important differential you keep in mind when you see pulmonary air cysts. LCH, LAM, tuberous sclerosis, neurofibromatosis, LIP, and subacute hypersensitivity pneumonitis, sometimes if the nodules cavitate, and end-stage fibrosis, which can be IPF or CEA, in which there will be typical honeycomb appearance. Yeah, so are you able to get your way around nodules and lung cysts to some extent?
Yeah.
Yeah, good.
Thanks. Okay, so frontal chest X-ray. There is bilateral hilar lymphadenopathy with some paratracheal, right upper paratracheal widening, giving sarcoidosis.
Very good. Simple, straightforward. Chest X-ray staging of sarcoidosis. Stage 0, normal X-ray. Stage 1, lymphadenopathy only. Stage 2, lymphadenopathy and parenchymal disease. 3 is parenchymal disease only. 4 is fibrosis. And staging is based on chest X-ray.
So again, frontal chest X-ray, there is Asbestos classification involving bilateral lungs, predominantly in the mid-zone distribution, with again some right hilar lymphadenopathy. And there's some nodularity again bilaterally within the mid-zones. A differential remain of sarcoid with lung involvement this time.
Very good. Yeah, hilar lymphadenopathy and nodules. Can you see the nodules? They are somewhat coalescing nodules. Yeah.
Yeah.
They can be alveolar plus interstitial, which is more likely sarcoid. If they were solely interstitial, like in LCH or in silicosis, they will be a bit more discrete and not coalescing to this degree. So that's the HRCT of the same patient multiple irregular nodules, subpleural nodules, peribronchovascular thickening along the bronchovascular structures, multiple nodules with irregular margins, with subpleural and peribronchovascular distribution, and peribronchovascular thickening is a feature of sarcoidosis. Now, can you your eyes can you differentiate them from lymphangitis carcinomatosis? Lymphangitis carcinomatosis will have uniform thickening of the interlobular septations rather than this shaggy, irregular, nodular appearance and peribronchovascular thickening. Are you able to confidently differentiate sarcoidosis from lymphangitis? Do you get the get the difference? Yeah. A lot more irregular, multiple nodules, and the pattern is much less of a interstitial thickening and more of a mixed central lobular nodules, peribronchovascular thickening nodules than a solely interstitial process like lymphangitis or other interstitial conditions. Is that okay? Is that confident?
Sure. Yeah.
Good. This is again sarcoidosis, which you have correctly diagnosed. So I'll skip through this: bilateral hilar lymphadenopathy and predominantly reticulations here.
Mm-hmm.
Yeah, and some nodules. Are you able to see the nodules?
Yeah.
And reticulations. Apices are spared. There is no volume loss. So since it's hilar lymphadenopathy and reticulations, we'll think of sarcoidosis. We can think of lymphangitis carcinomatosis, lymphoma, etc. Yeah.
Okay, so this is a frontal X-ray. There are some predominant changes in the peripheries of both midzones, with some coalescing nodularity and opacification extending up to the hilum. Again, the bases are largely spared. The apices are also clear. There is bilateral lymphadenopathy. So this would be in keeping probably with the late stage sarcoid with some fibrosis along the margins of the peripheries in the midzones.
Yeah, good. You correctly identified the parenchymal destruction of a chronic lung disease that affects parenchyma. This is distinct from the interstitial fibrosis, the chronic UIP pattern, isn't it?
Yeah.
Here there is parenchymal destruction and a lot of big fibrotic strands kind of altering the overall lung architecture. Unlike interstitial fibrosis, which is more of a uniform reticular pattern with volume loss, this is kind of non-uniform parenchymal destruction with no significant reticulation and so on. This is sarcoid, and this appearance can occur in TB. So there is another finding that you could pick up in this. Are you able to see that? If you have seen that before, you'll be able to make that diagnosis. Does it have?
This calcified lymph nodes in the hilar region, this maybe?
What kind of calcification? What type of calcification?
It's this eggshell type calcification, which we usually get in silicosis and
very good.
Interstitial lung disease. Yeah.
Can you see the rim calcification?
Yeah.
So calcification along the rim with central loosened areas. This is eggshell calcification that you can see in silicosis, sarcoidosis. Shell-like calcifications up to 2 mm thick in the periphery. To make a diagnosis, at least 2 lymph nodes, at least 1 complete ring, etc. And the differentials are silicosis, cold workers pneumoconiosis, sarcoidosis, and lymphoma post-treatment.
Okay, so this is a frontal X-ray. There is volume loss in both lungs with increased reticular shadowing involving the peripheries. The heart borders are shaggy. There's midline stenotomy. Oral appearances are of an underlying interstitial lung disease with fibrosis.
Yeah, very good. The first thing that you notice is that the lung is small on both sides, and then there are reticulations which are coalescing into some degree of ground glass, but that's fine. When there is extensive reticulation, they may seem like ground glass. So HRCT showing reticulations, ground glass, and
traction bronchiectasis.
Very good, traction bronchiectasis. So if you see this degree of ground glass, you have a bit unsure whether that's an acute alveolar process. But when you find traction bronchiectasis. Traction bronchiectasis, those are the arrows that I'm showing you.
Yeah.
Dilated bronchi everywhere. So peripherally distended bronchus, traction bronchiectasis, suggestive of a diffuse interstitial scarring process that is shrinking the lung and distending the airway, which is quite characteristic of UIP. Now, interstitial lung disease, the patterns, the types, etc., will be dealt with quite extensively in the next chest session by my chest colleague. Next, please.
So again, a frontal chest X-ray. There is diffusely increased reticular markings involving both lungs. Just having a look.
Distribution?
It's more at the bases.
Very good. Yeah, that's all. So reticulations, fine crisscrossing lines, more at the bases, and lung volumes.
Lung volumes are, I would say, slightly reduced, but yeah, slightly reduced at the
bases. Yeah, the bases are actually shrinking. You see the space, the lung, the space in the lung is so small on the left side here. So lungs are shrinking because of the diffuse interstitial process, and it's a classical pattern of UIP. Next one.
Okay, so again, a frontal.
Yeah, this is the same thing. You would make a diagnosis, reticulations.
Yeah, reticulations.
Yeah. I'll give you a CT for this case. See if you can diagnose.
So there is again traction bronchiectasis with some fibrosis, ground glass change in the bases. There is, I think, the esophagus is dilated, which would produce to be a connective tissue disorder, and I would think along the lines of scleroderma.
Yeah. Very good. So when you are presented a case of interstitial fibrosis, usually in the exam 2B setting, there will be other clues to make a complete diagnosis. One of which is a distended esophagus in the case of systemic sclerosis. The other would be erosion of the clavicles in the case of rheumatoid arthritis, or these could be pleural plaques, in which case you can make a diagnosis of previous previous exposures to asbestos and asbestosis, because lung disease is called asbestosis. Is that okay?
Yeah.
Good.
Okay, so again, frontal chest X-ray, there is some reticulations and volume loss of the lung bases. However, there are some coalescing shadowing in the upper zones, which are radiating towards the hilum. I'll be thinking along a chronic process, industrial process, maybe with the progressive massive fibrosis of the lung bases with background fibrosis and a underlying silicosis.
Yeah, I mean, that's a reasonable diagnosis, but there is reticulations in the bases.
The bases, yeah.
And there are nodules.
Nodules up, okay, yeah.
Yeah. So these are actually rheumatoid nodules on a background of reticulations, interstitial fibrosis. So, but that, look for other clues, which is unfortunately not there in this X-ray. Look for other clues like clavicular erosion, etc. Yeah. But keep rheumatoid nodules in mind when you see interstitial fibrosis. So connective tissue disorders, UIP, always look for connective tissue disorders, clues for rheumatoid nodules, clues for systemic sclerosis, clues for previous asbestos exposure, clues for previous exposure to chemotherapy. There may be a mastectomy or axillary clips. Yeah. How many cases, how long have you been doing? I lose track of the time.
Probably, I don't know, 20 minutes or something, maybe. I can't remember.
Yeah. Okay, maybe we will, I think we will move to the next person. 6 has raised hand. Is that okay? Thank you very much. You did very well.
Thank you.
Can you hear me, number 6?
Yeah.
Very good. This is your X-ray, number 17.
Sure. So this is frontal chest X-ray of an adult patient, which demonstrate deviation of the trachea to the right side, and there is blunting of the bilateral cosophrenic angle. And looking specifically at the left upper zone, I can see capacity around there causing potential mass effect to the contralateral side. There's this pure opacity tracking from the upper to lower zone in the left lung.
Yeah.
Similar
What
opacity.
about the hilar? Both hilar. Can you see the hilar point?
The hilar points are distorted.
Can you see the hilar?
Quite difficult to make out the hilar point. I think it's tracked up superiorly.
Yeah, the hilar are sitting up here
Sure.
on both sides. Yeah.
Yeah.
And there is a lot of shadows. When you see shadows like this, think of chronic pleural thickening.
Yeah.
Yeah. So both hilar are elevated. Differentials of bilateral hilar elevation.
So it will be upper zone fibrosis, such
Yeah,
as
I'll give you a lateral X-ray and see you can reach a diagnosis.
So taking into account of pleural thickening, I'm thinking post-radiation can cause bilateral pleural thickening.
Yeah. Now, can you look at this lateral X-ray and see if you can reach a diagnosis?
So homogeneous opacity seen in the upper zone, hilar traction superiorly, and loss of the spine sign. As we track inferiorly, it doesn't get more lucent. So I'm thinking, could it be a mesothelioma because of the pleural base pathology?
Is mesothelioma differential in bilateral apical fibrosis?
No. So you're looking specifically at this vertebral body. Here, there's increased density over the posterior vertebral body.
Have you heard of squaring of vertebral bodies?
Yes. So that is in acromegaly and also in Paget's.
Okay, that's one of the differentials.
Other causes of squaring of the vertebral body.
I'm pointing to something.
So that is the hilar, that is the bronchus.
This line, what's that line?
So that is
Calcified.
Oh, sorry, I was looking at my own cursor, sorry. Yes, that's calcified intervertebral disc.
Okay, calcified outer annulus. Annulus of the disc and squaring of the vertebral body. So putting bilateral apical fibrosis, squaring of the body, and calcified outer annulus. Yeah, very good. Upper zone fibrosis differentials are TB, histoplasmosis, chronic extensive allergic alveolitis, radiation, sarcoid, progressive massive fibrosis, and ankylosing spondylitis. Next case.
This is an adult chest radiograph which demonstrates bilateral upper zone patchy opacity. And there's loss of the hilar point which tracks superiorly. Yeah. And overall lung volume is reduced. So finding in keeping with upper zone fibrosis, causes includes pulmonary.
This pattern is quite typical of what?
Yeah. Progressive massive fibrosis in pneumoconiosis.
Very good, very good. So this large consolidations in the upper central lung and emphysema rest of the lung, and you can see some nodules as well within that. There's probably some background nodules as well. So this is progressive massive fibrosis, which is large mass-like conglomerate shadows in the upper medial lungs with radiating strands. And then the causes are pneumoconiosis, especially cold workers pneumoconiosis, silicosis, and torcosis. Next one.
So frontal chest radiograph of adult patient which demonstrates opacity which appears to be pleural base, calcified opacity bilaterally.
Very good. Diagnosis?
Asbestosis.
Yeah. What would you do next? This comes in your reporting pile.
So I will always refer to compare to previous to see if there is a chronic change.
Excellent. No, don't ask for CT. Compare the previous. Okay. Can you see that white line? It's a bit faint, but can you identify that white line?
Yes.
What is that relative white line there?
So it could be a pleural plaque in the diaphragmatic surface.
Very good. So that's the point of this X-ray. That's the point of highlighting that. Learn to identify diaphragmatic pleural calcification, which is characteristic of previous asbestos exposure. Yeah. So look for these white lines. It may not be the diaphragmatic pleural calcification may not be along the dome of diaphragm, because if you imagine diaphragm, it's not a uniform round structure. It has got its undulations. Yeah. Especially when there is calcified pleural plaque sitting at one part, that part may not go up and down. So it may be projected in front of the diaphragm, the diaphragmatic white line of calcification. Yeah.
So the frontal chest X-ray of a adult patient which demonstrate patchy opacity in the bilateral lower zone.
What is the pattern of opacity? How would you describe it? Is it acinar shadows? Is it reticulation? Is it reticulonodular?
It seems like reticulonodular on my screen.
Very good. Yeah. Bilateral, basal, reticulonodular opacities. So differentials?
So it would be lower zone fibrosis, UIP pattern or NSIP pattern, looking specifically at
now, there is something else in the X-ray that can take you to a diagnosis.
So I'm looking for shoulder arthropathy and whether is there any dilated esophagus I can see. I can't see that.
No. Bones are fine. Yeah.
Yeah, I'm looking at whether is there any pleural masses, any calcified pleural base lesion. I can't see that either.
Are you sure you can't see any pleural abnormality?
On further interrogation, I can see bilateral mid zone at pleural base opacity.
Very good. Are you referring to this one?
Yeah.
Very good. You know, remember that pleural plaques start as soft tissue density thickening, and then only they eventually calcify. Okay, so pleural plaques can be non-calcified as well. So there is a little bit of pleural thickening, which you correctly identified. So with pleural thickening and basal reticulonodular opacities, your diagnosis is?
Asbestosis.
Previous asbestos exposure and asbestosis in the lung. Yeah. When you say asbestosis, that pertains to lung interstitial fibrosis.
Okay.
When you don't see lung interstitial fibrosis, you don't say asbestosis. You say pleural plaques or previous asbestos exposure. Manifestations of which can be pleural effusion, which can be pleural thickening, and calcified pleural plaques. Good. Next one.
So this is a cone-in view of the mediastinum of an adult chest X-ray. First thing to note is this bilateral scatter pulmonary nodule. I can see the biggest in the right upper zone.
Very good. So you have managed to identify the small nodules. Yeah. Some of them are they are non-uniform. Some of them are big. Pattern. So you remember number 4. As soon as you identify nodules, the next is distribution of the nodules. Pattern of the nodules. Yeah. Distribution and pattern.
Upper zone predominant.
Yeah. Upper and mid. Are they? When you say upper, they should involve the apices to call it upper. Otherwise, it's upper and mid. So there are mid lung nodules as well, isn't it?
Yeah.
Yeah, good. So that's actually subsequently, so a lot more nodules. They are slightly greater than soft tissue density. So diagnosis or differential? Yeah.
Right now, I'm trying to see. Previously, it was upper to mid zone distribution, but right now there's some lower zone involvement as well.
But do they involve the base?
No, it's still predominantly upper mid.
Yeah. And do they involve the apex?
No, it's sparing apex.
Very good. Yeah. So diagnosis or differentials?
So it could be pneumoconiosis.
Yeah.
Sarcoidosis.
And yeah, totally. Those are the differences: silicosis, pneumoconiosis, sarcoidosis. This I would have thought a bit more pneumoconiosis because they are little denser than soft tissue or metastasis. Yeah, very good. Next one.
Sure. Erect chest X-ray of adult patient which demonstrates a potentially a drain in the left pleural space, and also there is generalized patchy opacity involving the entire left lung. The left claustrophrenic angle is not well seen, and there's obliteration of the left hemidiaphragm contour. So the presence of the drain, I'm thinking whether is there any pleural effusion, underlying pleural effusion cause which warrant the insertion of the drain. And looking at the opacity, I can see some lung marking behind there. I'm wondering whether is this opacity pleural based or within the pulmonary parenchyma. Trying to decide that, I can see some air bronchogram to the opacity.
Very good, yeah.
Which point towards this
bronchograms, yeah. Oh, look at all the bronchograms for the benefit of all others. So look at all these air bronchograms, which means it is a large lung consolidation, and the pattern is
upper to mid.
Yeah. So differentials would be, or the diagnosis in this case would be?
So it's a unilateral process. I'm trying to see whether there's no bilateral.
If it was, since you said unilateral, if it was bilateral, what would you have considered? If this pattern of large lung consolidation exactly appeared on the right side as well, what will be your first diagnosis?
Infection wouldn't be. I'm thinking of infections of pulmonary edema, but
yeah, I would have considered pulmonary edema first.
Yeah. So it's unilateral now. I see absence on left breast shadow. I'm thinking whether it's the post-radiation changes.
Yeah, that's a differential. Yeah.
Because it's a unilateral process.
Yeah, acute radiation pneumonitis is a differential. It's quite unusual to irradiate the entire chest.
Yes.
Yeah, they irradiate the area of the breast, which is a smaller area. So you do find usually the post-radiation pneumonitis will be confined to the lower part of right upper lobe, or lower part of the lower lobe or the middle lobe. If you report CTs, you would come across that. So it's very unlikely for the entire chest to be involved.
Mm.
Yeah. So it's more likely pulmonary edema.
Okay.
Unilateral pulmonary edema. And to put
patients lying on the left side.
That's one differential. And the other differential is, since you spotted this,
the tube.
Yeah.
Could the tube be in the wrong position? No.
Okay, let's go through the differential of unilateral pulmonary edema. Yeah?
Yeah.
So pulmonary edema ipsilateral to the side of the abnormality. Oh, this is actually taken from the from Chapman. Unfortunately, this doesn't say the diagnosis of that. Oh, yeah. Number 2 here. Can you see this?
Yeah.
So rapid lung re-expansion post thoracocentesis.
Okay.
So first one is your diagnosis, prolonged lateral decubitus position. But because there is a chest drain, you can consider rapid lung re-expansion post thoracocentesis, which is the diagnosis in that case. They put a drain and then drained more than 2 liters, more than 1 liter of fluid. I think they should drain only 1 liter of fluid in 24 hours. Otherwise, there will be a rapid lung re-expansion and resulting in unilateral pulmonary edema. And then aspiration, contusion, and all these differentials which you can go through. Okay, are we good?
Yeah.
Good.
So HRCT selected slices of a patient which demonstrates geographical patchy ground glass opacifications and this area of air trapping within the lung parenchyma. which in keeping with hypersensitivity, and I can see the sparing of the subpleural region. Finding most in keeping with hypersensitivity pneumonitis.
So, what's the appearance called?
Sorry, what score?
What's the appearance called?
Head cheese sign.
Sorry?
Is it head cheese sign or crazy paving? Because there's some septal thickening here.
Very good. Very good. So there is ground glass. Why is it ground glass and not a consolidation? I did tell you how to differentiate ground glass and consolidation previously. Because in ground glass, the bronchial tree is not obscured. The pulmonary vessels are not obscured in ground glass. Now you can see the pulmonary vessels, can't you? You can see the pulmonary vessels here. If it is a consolidation, that the amount of tissue in the alveoli are so much that obscures the pulmonary vessels. But here you can see the vascular structures everywhere, so it's ground glass. Yeah. The second part is, in addition to ground glass, you are seeing thickening of the septations, interlobular septations. There is crisscrossing appearance. There is septations. It's not purely ground glass. There are thickening of the septations as well. So everywhere there is thickened septation. So this is combined ground glass plus interstitial thickening, which is called crazy paving. And the differentials of crazy paving are? Just a magnified view to show the ground glass as well as thickening of the septations. So those are the thickened septations, interlobular septae, and so on. Yeah, crazy paving differentials. We know alveolar proteinosis, bronchoalveolar cell cancer, which is nowadays called adenocarcinoma of the lung, diffuse type, lipoid pneumonia, PCP pneumonia, all the causes of pulmonary hemorrhagic syndromes, and non-specific interstitial pneumonia. Next case.
So this is a chest radiograph of a patient, which demonstrates complete or pacified lung bilaterally with air bronchogram within, in keeping with consolidated lungs, mid to lower zone predominant, sparing the upper zone.
So the density in the lung, are they more dense or less dense than the bones?
More dense than the bone.
A lot more dense than the bone, or marginally more dense than the bone?
A lot more dense than the bone.
So is it just inflammatory pus that is accumulating in the lung, or is it something that contains a dense object like calcium or whatever?
Yeah, it could be. Yeah, it could be calcium or barium if it gone into the lung.
Yeah. Have you ever seen so much barium going into the lung?
No.
Yeah. So what's the diagnosis? If you know it, then you know it.
Is it malignant pulmonary calcification?
Yeah, that's metastatic pulmonary calcification is a differential. Yeah, but a commoner appearance of this is that's, you know what that black line is? Can you see the black line here?
Yeah.
So that black line you can appreciate along the lateral chest wall as well. If you have heard this, then you know it. Otherwise, these are called negative pleura sign. Yeah, because the density in the lung is so, calcium deposition makes the lung so dense, relative to the calcium filled lungs, the pleura appears as a lucent line. That's called negative pleura sign, and the diagnosis is?
Ran out of bright ideas. I don't know. Sorry.
Pulmonary alveolar microlithiasis. Okay, so this is an advanced degree of pulmonary alveolar microlithiasis, and the condition is a genetic mutation. Females are affected more than the males. They are associated with testicular microlithiasis. It's actually sand-like deposition of calcium phosphate in the alveoli. and negative pleura sign is quite characteristic. And their prognosis is fairly good. They only very rarely progress to pulmonary fibrosis and requiring lung transplant. So keep this in mind: pulmonary alveolar microlithiasis, diffusely spread calcifications in the lung.
Sure. So this is a frontal view of a bone scan which demonstrates diffuse intense uptake within the lung, and also the appendicular skeletal of the patient. So focusing at the intense uptake within the lung, it could be present in alveolar microlithiasis.
That's one, yeah. But alveolar microlithiasis, does it give this appearance?
No.
That is what?
I'm thinking. I'm deciding whether it's a stomach or spleen. I think it looks like stomach.
Yeah. So there is deposition in the stomach as well. Okay.
Okay.
And is it a super scan? Have you seen super scans? Where is the kidney?
It's not demonstrated yet.
Yeah. So it's probably a super scan. Quite avid uptake in the lungs and stomach, which is actually this is what you said: metastatic calcification in extreme hypercalcemia due to various causes. So extreme hypercalcemia causing extreme calcium deposition everywhere. Metastatic calcification in all these conditions. I think this will be the last case in this session, and then we'll take a break and continue. So sorry, beg your pardon, you are number 5 or 6?
6.
6, okay. So next will be number 7. So what is this X-ray showing?
So scatter diffuse pulmonary nodule of varying sizes with random distribution, no zonal predominant.
What is the density of the nodules?
It's hyperdense, almost isodense to the bone.
Yeah.
To the calcified nodule.
Yeah. So diagnosis?
So diagnosis includes previous viral infection with calcified adenoma.
This is varicella pneumonia. The appearance of multiple calcified nodules.